No oxygen, no survival. And if the lungs become nasty and troublesome, they can cause painful breathing, which is really hard to experience. Greetings everyone, have a bunch of information on sqadia.com. In this video, you are going to learn about pleural effusion. Let's see what it is. Pleural effusion is basically water on lungs or extrinsic fluid buildup. It must not be confused with the term pulmonary edema, which is water inside lungs or intrinsic fluid buildup. There are protective thin membranes outside the lungs termed as pleura. If we zoom in, we can see a visceral pleura. As viscera mean body organs, so this layer is exactly outside the lungs and then enfolds at the hilum and then forms parietal pleura, which lines inner side of the chest wall or thoracic cavity. Hilum is basically a place where pulmonary vessels enter and leave the lungs. Parietal pleura is thicker than the visceral pleura. Between these two pleura, there is a potential space, termed as pleural space or pleural cavity, which is filled with the fluid. This fluid provides lubrication to expanding and contracting lungs. But how come this fluid is here in the thin space? The answer is fluid comes here from capillaries of pulmonary and systemic circulation surrounding the lungs. It is reabsorbed or removed by lymphatic system. If there is high fluid production and less fluid reabsorption, it results in excessive accumulation of fluid in the pleural space, which we call pleural effusion or simply excessive fluid in the pleura. Well, let's find out reasons behind increased fluid production. As we know, fluid moves from capillaries to pleural space. If there is any type of inflammation, mediators and cytokines are released, which bind on the blood vessels and make them more leaky. That's how fluid accumulates in the pleural space. Primary causes of increased fluid production are increased hydrostatic pressure and decreased oncotic pressure. Let's begin with the increased hydrostatic pressure. Hydrostatic pressure is defined as pressure exerted by flowing blood on vessel walls. It is high in situations like heart failure because heart becomes inefficient in pumping blood. Hence, blood is retained in pulmonary vessels. As a result, pressure raises and more fluid leaks out into the pleural space. Next is decreased oncotic pressure. Oncotic pressure is a form of osmotic pressure exerted by proteins in the blood. Due to the large protein size, they are unable to leave blood vessels. And if protein level is low in blood, oncotic pressure will be low. Here, due to osmosis, which is movement of fluid from low solute concentration to higher solute concentration crossing the membrane, fluid will leave capillaries from low protein concentration to higher one, that is pleural space. Well, reason behind low protein content is less protein production due to compromised liver, which is the production site for majority of proteins such as albumin. Now, let's hover over decreased fluid reabsorption. Fluid is normally drained via lymphatic system. But in some conditions like thoracic duct damage, lymphatic drainage is blocked and results in effusion, that is, fluid buildup. Chylothorax is one of the rare conditions resulting from thoracic duct damage. In this case, lymphatic fluid leaks into the pleural space, resulting in lymphatic pleural effusions, which are milky in appearance. Thoracic duct injuries are usually caused by radiation therapy, tumor in lymphatic system, and surgery. If you want to explore more about transudate versus exudate, sign and symptoms, diagnosis, and treatment, hit the play icon to watch the upcoming parts.